So we're going to talk about first trimester pregnancy and pelvic ultrasound. This is obviously an ultrasound that in our emergency department we don't do as often as we as you may do in your future job. So we're going to spend a little bit of time on this. We do this particular workshop every single year to give you guys a chance to practice pelvic ultrasound with both transabdominal, which you should be familiar with because of the FAST exam, and also endovaginal or transvaginal protocols. We use this to diagnose intrauterine pregnancy, and there's a couple other things that we'll talk about as we go through, and then talk about how to implement or how to combine the ultrasound into your clinical management. So first, just a couple of cases. 21-year-old woman who was hoping she was not pregnant, so she checked a pregnancy test 4 times. She's coming in with left lower quadrant discomfort, otherwise pretty stable. So that's our first patient we're going to talk about. 22-year-old with a positive pregnancy test. She has a little bit of spotting and some cramping. Our third test is a 23-year-old who doesn't know if she's pregnant or not. She's got some abdominal discomfort and vaginal bleeding with a fair amount of clots. And the last patient that we'll kind of circle back around to at the end of this is a woman with lower abdominal pain, last menstrual period 2 weeks ago. She has a pregnancy test, but she doesn't think she could be very pregnant since she just had her period. So these are our 4 patients, and the question is, which patient needs ultrasound? And as I'm ultrasound faculty and this is an ultrasound talk, I bet all of you can guess what the answer is to that question. So we'll show their ultrasounds at the end. All of them. You already skipped to the end? Shoot. Causes of bleeding and pain in early pregnancy is usually what brings these patients to us in the emergency department. Some of these things can be pretty benign, like implantation. Some of them can be uncomplicated from a medical standpoint, but very problematic for the patients, like miscarriages, subchorionic hemorrhage, and then obviously ruptured ectopic and heterotopic is problems for both them and for us that we have to figure out. So that's what the focus of today is going to be on, is on the ruptured ectopics. There's multiple indications for ultrasound of the pelvis in the emergency department, not just in pregnancy, in which case an ectopic could present with just bleeding or just pain, but also pelvic pain in non-pregnant patients. This can be a useful tool for you to take a look at the adnexa, look for free fluid and things like that. And then the last but not least is there's been several studies that show that in a busy emergency department, this significantly saves you time. So if you think about the time that it takes a patient to disappear to radiology, come back, and then get a read, it doesn't surprise or shouldn't surprise anybody that the couple of studies that are listed here at the bottom actually showed that patients' length of stay was decreased by 30 minutes to up to 2 hours. Ectopic pregnancy is not a particularly rare diagnosis. For those of you who work in our emergency department here, we've actually had a fair number of ectopics, and this is because we have a significant selection bias. So ectopics are not as rare as you'd expect them to be. About 2% of all pregnancies are ectopic, but we see probably 3 to 13% in emergency departments across the board. I suspect that our numbers are a little bit higher, just knowing anecdotally what we see when we're working on shift. Interestingly, I think this last statistic has nothing to do with ultrasound, but it's just helpful clinically. Only 60% of women with ectopic report a missed period, which means 40% of women didn't even know that they were pregnant until they got a pregnancy test, because they thought that they're only, if the most, 4 weeks along, because they think that they had a period. Which just goes to show you how difficult it is to differentiate normal bleeding and periods or whatever else they're reporting as a normal period. On ultrasound, it's hard to find ectopics. In emergency departments, or point of care ultrasound, we probably get about 60% or so of ectopics are found. There's usually kind of adnexal masses and things like that. However, you don't need to find the ectopic. You really just need to find the uterus, make sure there's a pregnancy in it, and if there's not a pregnancy in the uterus, then it's a pregnancy of unknown location, and then clinically managed from there. We're very good at that. If we can find the uterus, we can usually find the gestational sac, and we're somewhere in the 95 to 99% sensitivity for ectopic pregnancy by using those criteria of there's pregnant somewhere, it's not in the uterus, and moving forwards. A question that comes up less often in the emergency department, but I still sometimes get questions about it. Like if you're calling somebody in the middle of the night in order to do the study, and that's, do you wait for the beta HCG? The beta HCG is a bell curve, and so a fair number of people present with outside of the standard deviation. And the standard deviation is not going to include things like ectopic pregnancies, because those aren't going to increase the beta HCG as fast as you'd expect it to. Early twin pregnancies can also be outside of this bell curve because you have twice as much pregnancy producing hormone, but they're only developing at the stage that they're at for the twin pregnancy. And then molar pregnancies obviously are on the other side of the bell curve because they're very high, and the pregnancy is usually farther along than we expect it to be from what we can see sonographically. Okay, so there's not actually a Loch Ness Monster, but that was a cool video. The beta HCG level is a little, you have to be cautious with it because even really low numbers can still have an ectopic pregnancy that ruptures. And a third of them, you would never even get the ultrasound if you followed that discriminatory zone. Remember that discriminatory zone is you should be able to see something on ultrasound at 1500 to 3500. It does double every 2 to 3 days. We're taught to have people follow up in about 48 hours. I sometimes, if I'm not very worried about somebody and I think they're early pregnancy, I'll sometimes do 72 hours if it's just more convenient, like over a weekend or something like that. Because really 3 days it should be double, but 2 days it's like, I don't know, it's kind of doubled, it's not quite there. It's a little bit harder for the provider on the other side to catch up. The bottom line is, if you're looking for ectopics, you just have to find the uterus. You have to find out if there's something in there. And then I would recommend you do the next step as well and get this into your thought process, is that once you find the pregnancy, make sure there's a uterus around the pregnancy. Because otherwise, sometimes we find that pregnancy and get so excited about finding it that we forget to go back and double check and make sure that it's actually in the middle of a uterus. Where else could it be? Most of them are in the fallopian tubes, 95% of them. There can be in other places, ovarian, interstitial, which means that they kind of develop halfway into the uterine wall. Abdominal, very rarely, but they can escape the entire GU system and go implant someplace else. And obviously heterotopics are a discussion for probably a different time, except for knowing that they do occur. In patients who are not undergoing fertility treatment, it's 1 in 30,000. So it's pretty rare. You may see one maybe in your career. 1 in 8,000 for fertility patients, but most of those patients are being monitored very, very closely because of this, this very known statistic. This is how we're going to talk about next, about the logistics of scanning. How do you do this? How do you actually move the probe? And then we'll talk about pictures, what we're looking for, yolks and holes. And then last thing is, once again, make sure the pregnancy that you find is in the uterus and that there's a uterus around that pregnancy. Probes. So you guys know this very familiar curvilinear probe from FAST exams and all your other abdominal exams. So this is going to be pretty familiar. I would like to tell you, don't be scared of this probe. It is very similar to this probe up here. It just happens to be on a long handle and you can't see the end of it when it's in somebody. That's really the only difference between these two probes, is just that you can't see what is going on with this. And so your haptics are just a little bit different. So this probe has a trigger on the bottom. On the opposite side on the top is an indicator. So this is what matches up with that little dot on the screen. And then if you look at the end of this probe, the curvilinear transducer face just curves around the front of the probe. So you get very good visualization of whatever that probe is up against. Of course, there's a reason why we use these two different probes. This is a low frequency probe, and so it has very poor resolution, but very good penetration. And so oftentimes we see fuzzy, like we'll see there's a gestational sac there, but we can't differentiate what's in it. Versus this high frequency probe doesn't go very deep. Most of them go less than 10 centimeters, but we can see very, very good detail of what we're seeing inside the uterus. So just in going forwards and trying to show you that it's not really scary. This isn't supposed to be scary. So this is a sagittal view of the uterus. So fundus up here, body of the uterus. Down here is the cervix, and this is air in the vaginal stripe. This is your standard curvilinear view that you see at the FAST exam. So the patient's head is up here, their feet are down here. This is the exact same view with the transvaginal probe. So here's the fundus of the uterus, here's the endometrial stripe. The cervix is cut off a little bit because of air artifact, but we're seeing that this is up towards the patient's head over here. This is down towards their feet. Maybe their head's up here. And then this indicator is kind of up towards the ceiling. This is scanning through in a curvilinear probe. This particular patient has an IUD, is this big bright circle here, or big bright line, which then turns into like a little T-arm right there. So we're scanning through. This is just standard sagittal view that you're familiar with. We're just sliding that probe back and forth. This is standard view with a transvaginal probe. So same thing. Now we're just tilting that probe back and forth. So we're looking at the fundus here, endometrial stripe. Cervix is down a little bit off the page again. This is a little bit of free fluid back here, which isn't too uncommon. And then bladder's up here. So this is up towards the patient's, it's up towards the ceiling, because this is bladder up here, and then this is down towards the patient's tailbone. This is what where your probe is sitting. Here's another view, same thing. I'm going to go just scan all the way through. Here's the endometrial stripe. Here's the fundus up here. Making sure we see the whole thing. The only thing we're not seeing right here is the cervix. So if you need to see either the fundus or the cervix, the next step you do is tilting. What they're doing right now, the movement that they're doing, is they're swinging the probe back and forth. So if you need to see a portion of the uterus that you're not seeing, then you just tilt the probe down for the cervix or up towards the fundus. So here's cervix down here. You can see the air kind of coming out of the end here. Endometrial stripe up here, and then bladder above it. So this is the movement that you're doing. This probe, I'm going to talk about this in a couple slides, but this probe seats up against the side of the uterus right here. So this the vaginal tissue is a little bit stretchy, and so as you're putting it in, you actually end up seated up here. It doesn't go like down here at the cervix where you sort of expect it to, because we think about these anatomy pictures from Netter as being very stiff, but this is all flexible tissue, and so you really end up right here on your ultrasound. This is, sometimes your uterus is not where you expect it to be just because it's folded in a different direction. So we like the uterus folded towards the bladder, but some people are retroverted and retroflexed. You can still do these ultrasounds with it. Sometimes you just have to finagle that probe a little bit tighter up against the wall of the uterus. There'll be some views later on as we look at positive findings so you can see what that looks like on endovaginal. So just like curvilinear, you want to get your transverse views as well as your sagittal views. So, whoops, not sure why that's not playing. Here we go. So here's sagittal view, and then for curvilinear, you just spin the probe like this, and then you're in the transverse plane. Okay. So with the endocavitary probe, instead what you do, instead of spinning the probe, is you rotate it. And you want to make sure that you're rotating it counterclockwise so that indicator ends up on the patient's right-hand side, so that you know that this is the right side of the uterus and this is the left side of the uterus over here. So if you find something in the adnexa, you can identify which side you're on. So this is what it looks like in transverse view. You have a nice round uterus. There's an endometrial stripe right here. And then actually, interestingly, this is a great view for finding ovaries because the fallopian tubes kind of come off the sides, one over here and then one over here. And the bladder is this like black fluid collection above it. So this is for reorientation. This probe is now, this is over towards the patient's right hand side, this is the left hand side. So this is now the ceiling, and this down here is now their tailbone. So this is a different patient's uterus, same uterus, two different views. So sagittal is on the top. See a little bit of the cervix down here, fundus here, and then this is the transverse view. It's easier to see the cervix and long axis than short axis, just because it's more comfortable for the patient. So now we're going to talk about, now you've done all the movements and sort of started to practice in your brain what you're going to do with the probe in order to find these things. Now we're going to talk about what you actually need for credit. First of all, if you're going to grab the probe, positioning helps. So you want to make sure that you don't have the patient in a regular bed, because what will happen is as you try to get up towards the fundus of the uterus, the probe will actually physically hit the bed, and you actually won't be able to get it up at a sharp enough angle to get it anterior enough to see that fundus. So you need to be at the end of the bed or on a pelvic bed in order to get that handle enough room to move. Alternatively, if you don't have that, a lot of times we'll use the bedpan and blankets method in order to just get them into some sort of hip thrust up so that you can actually have room to move that probe around. You should always do your transabdominal ultrasound first, because sometimes people's dates aren't quite right, and it's really hard to figure out. If there's a confusing picture, it's really hard to figure it out with the endocavitary probe, just because it doesn't go particularly deep. Dr. Takesa shares a story of a co-resident during his residency who diagnosed somebody with an ectopic pregnancy, got everybody all excited about it, until they found out that really what he had been seeing is not free fluid and bowel, but a baby foot in a intact placenta and uterus. And that's because they started with the endocavitary probe instead of doing the transvaginal probe and ended up with something like this. So here is nice normal uterus. We're just scanning through it in sagittal view. So here's fundus up here. This is transabdominal, and so you can see there's something in that uterus. There's a gestational sac or something there, but we really just can't get the definition that we need in order to diagnose this comfortably as a pregnancy. So we already talked about briefly that this ultrasound seats up against the anterior wall of the uterus. So as you're putting it into the patient, what you need to do is watch the screen. So you ask them if they want to place the uterus if they want to place the endocavitary probe into the vagina, or you can place it, whichever is their preference, and then slowly push it forwards while you're watching the screen. You should watch the bladder go by, and then you should watch the uterus show up. If you don't do that, what will often happen is you'll go down here. Remember, this is pliable tissue, and you actually end up ultrasounding a bunch of bowel contents, and you can't find the uterus anywhere. So if you can't find the uterus when you put the probe into the patient, just pull back. Almost everybody is always just too deep. You want to optimize your depth as your next step. So this is a beautiful ultrasound that is done on a patient who actually we needed to know if they had an ectopic pregnancy, but it's completely non-diagnostic because the fundus is over on this side of the page because they didn't quite get deep enough. This is a beautiful ultrasound that is diagnostic, but they could have used the other half of their screen that's sitting down here just to get some better definition and make it easier to find fetal heart rates and things like that. So what we're looking for is the sonographic stages of first trimester pregnancy. Gestational sac is non-definitive. So it's really just a fluid collection in the uterus. We go to a yolk sac, then a fetal pull is the next step, and then, cardiac activity. And this is very, very regular. So when you find this, you can actually give the patient a little bit of an idea of where they're at for their dates. So at 5 weeks, it's just fluid. That's all it is. Fluid in the middle of the uterus. If you find out later, this is one of those retrospectoscope things. If you find out later that they didn't actually have an intrauterine pregnancy, then it's a pseudo-gestational sac. But nobody really knows what it is when they're looking at it. So this is a picture of fluid within the uterus that is probably a pregnancy that just hasn't gotten quite far enough along. So we have uterus, nice rounded fluid collection. Those have a tendency to be actual gestational sacs. At 5.5 weeks, we have a yolk sac. And this is the most beautiful thing when you're on shift, you're in a hurry, and you just need to get this patient to the next step. because all you do is you go through, you find a perfect little itty bitty Cheerio circle, and that's all you need. And then you know that their pregnancy is where it belongs. All you need to do is get that patient to get follow-up with their OB. This is sometimes only visible in one plane of imaging, so if you can't find it on one side, then you rotate the probe and you scan through the gestational sac in the other plane, because sometimes for whatever reason it only shows up on one plane. Here's another example, same thing, cute little itty bitty yolk sac in the middle of this uterus. So once again, remember, you look for the sign of pregnancy within the gestational sac, and then you do one more look around everything else that's around you to make sure that there's actually a uterus all around that area and that this isn't an ectopic pregnancy that just looks kind of similar. We'll see ectopics in a minute. Here's another, this is a transabdominal view. So it's perfectly legal that you do transabdominal. You don't have to do transvaginal. This one, it's always a little fuzzier, but here's a yolk sac right here and there's a fetal pole down here. Speaking of fetal poles basically just the schmutz that starts to grow in between the yolk sac and the wall of the gestational sac. It is what the baby, it's what's going to be the baby. The yolk sac disappears eventually. I find that usually by the time I'm finding fetal poles that are very obvious, there's a heart rate in there too. So I think I'm not very good at picking up fetal poles until we get up to about 6 weeks or so. So here's another little fetal pole with a cute little yolk sac. There's the fetus, there's the yolk sac. This is a beautiful example of a double decidual sign, which is this kind of bright white around the uterus, around the gestational sac, and then there's like a little bit of darkness around it as well. If you see that in radiology reports, that's what it's about. They're talking about this kind of echogenic area around the gestational sac that shows up in pregnancy. One more, this is another transabdominal example. Like I said, it's legal to use transabdominal. As long as you can see a yolk sac and or a fetal pole in there, it is legal and they have an intrauterine pregnancy. 6 weeks, cardiac activity. This is really challenging when the baby's very small because like every single time the patient moves, the baby like moves out of plane. But basically you hit M mode, you put this tracer, this bar across where the fetus heart rate is, you hit M mode again and you get this nice, beautiful little repeated pattern. If you can't see it well enough, I reproduced it up here. And then you hit caliper. And then you get the two little crosshairs that you use to measure things like gallbladder walls and fetal poles and things like that. If you hit this button down here, this button right here is a button that corresponds to this, this display that says there's a heart and it says HR for heart rate. Hit this button, it turns into these two long lines, which then give you a measurement of time. You can use that for like adults' heart rates too. Cardiac activity. So if you do a clip of just holding the probe still, you can sometimes see these two tiny little pixels just kind of moving back and forth. It's another one of those things that when you see it, you didn't realize you were nervous until you see it, and then you're like, oh good, everything's fine with this pregnancy. If you want to estimate gestational age, which is required, you make sure you're on OB settings. If we're not on OB, this is usually when we notice it. Up till now, it didn't matter. We just sort of adjusted gain and things to get her out of it. Hit exam, switch to OB, and then you can hit calcs, and the gestational age calcs will show up for you. We usually use crown rump length for babies at this stage of pregnancy, just because it's going to be the most accurate, and they usually don't have enough femur to measure. What you do is you measure top of the fetus to the bottom of the fetus. Don't measure limbs. Don't measure the yolk sac. And you should get a nice little measurement down here once you hit your calcs. You can measure gestational sac if they're like, wow, you have a big gestational sac. I don't know how far along you are. You can go ahead and measure the gestational sac if there's not a fetus to measure, so you can get a sense as to kind of how far along they were or when the pregnancy stopped progressing. Here is a view of a uterus. Now we got to do the fun things, which is actual clinical examples. So here's uterus right here. I think this is an ovarian cyst. It's just sort of shoving the uterus over. And then over here we have, what's this over here? A little Cheerio. So Cheerio. Yeah. So there's a baby trying to be made over here, but the problem is that This gestational sac is not anywhere near the middle of this uterus. So this is this uterus over here. This is the endometrial stripe. This is a little pseudo-gestational sac in here as well. Right there. So this is not where it belongs. These are the ones that are hard to catch. This is the ones where you find the baby, you're like, I'm so excited there's a baby, and you see this tissue around here and it really looks like uterus. That's where you have to do that double check and be like, now that I've seen it, what's the big picture again? Here's another picture of uterus right over here. So big uterus, endometrial cavity right here. Once again, what's over here? There's gestational sac, cute little yolk sac in there. Where is it? It is not over here where it belongs, because this is, it is a sad lecture. It's very sad. Remember, this is only 3% of cases, but they're deadly, and that's why we have to find them. So that's why it's a sad lecture. Okay, so scan all the way through the uterus so you don't miss things like twin pregnancies, ectopics, misplaced pregnancies, which is, we'll talk about in a second. So here we are scanning all the way through. Once again, here we have a big fluid collection over here that isn't where it belongs. It is not inside the uterus. This is an older view. Another one. Uterus. What's in this one that we haven't seen on the others? There's a puddle. There's a big puddle of free fluid in this one. So this is a ruptured ectopic. So here's the uterus over here, endometrial stripe right here, bunch of free fluid all around it. If this patient has any signs consistent with ectopic pregnancy, then it's just to go to OB. Eccentric pregnancies, so pregnancies can grow in the horns of the uterus, or they can implant a little bit into the wall. So you always want to make sure that you do a quick look on the edge of it and make sure that there's enough uterus around it that it's going to be safe for the patient to continue to develop. This is otherwise considered basically the same as an ectopic pregnancy. You want this to be at least half of a centimeter, more than half a centimeter wide. Between the gestational sac and the edge of the uterus. You also want to make sure that you check the cervix. You can have a gestational sac that is implanted in the cervix. This happens to be one that is just being miscarried. So you can see they're tilting down to see the end of the cervix down here. I don't really look at the fundus much on this one. And then this patient is profoundly ill, vomiting all the time. Is like 7 weeks pregnant. What do you guys think about this? What's this diagnosis? Yeah, there's grapes. There's ultrasounded grapes here. And I'm not really sure about the snowstorm, but obviously this needs to be diagnosed. They need prompt referral to OB. Blighted ovum. Once again, it's a sad lecture. This is really tough on patients. They've been so excited about this pregnancy, and then one day they find out you actually haven't been pregnant for a while. Your body hasn't figured it out yet. So they have these big gestational sacs, nothing in them, because the pregnancy has stopped coming, because pregnancies have to be perfect. Life has to be perfect in order to move forwards. And so the body's like, meh, this isn't working, not going to do it. And they just haven't gotten around to having a miscarriage yet, or letting the patient know that that's where they're at. So a little bit of free fluid behind the uterus is not unusual. I promised you a retroverted uterus. This one's not really retro. This one's a retroverted but anti-flexed. It's kind of a funny position. A little bit of trace fluid back here. That's not uncommon. It is uncommon to have enough fluid up here that you're seeing it above the fundus as well. So this is not an unusual amount of fluid. You'll often see it. This is an unusual amount of fluid. So this is a bladder. I think this is actually an ovarian cyst over here. This is transabdominal view, so a bunch of fluid all around it on both sides. It looks pretty complex, and the contents in the uterus are pretty complex too. When you see this, we do a right upper quadrant view to see how much fluid is in them. These are often the patients, either patients that show up and they've syncopized, or they look like they're tachycardic, but have normal blood pressures because there's these young, healthy women. And so always consider that possibility of checking in the right upper quadrant too if you're worried about ectopic pregnancy. So the workup is you want to always make sure you get a quantitative HCG and a CBC, but none of that is actually for you. That's actually for somebody else in follow-up. They will need to know what this patient is. Today, when they follow up with them in a couple of days, if they continue to have bleeding, they need to know what their CBC was and need to know what their quantitative beta-HCG was at that point in time. If they know their RH status, then obviously you don't need to type in screen, but if they don't, then you need to get that as well. And consider ROGAM if they're RH negative and having bleeding. Obviously you need IV access, you want to do a pelvic exam and an ultrasound. So this is the disposition. If you find something in here, plus or minus the fetal heart rate doesn't really change much about what our disposition is. You're going to estimate gestational age, you're going to give them threatened miscarriage instructions because presumably they're there for some reason, and have them do OB follow-up or with their primary care doctor if their primary care doctor does OB follow-up for early pregnancy. If there's not an intrauterine pregnancy, so if there's just an absence of it and you think it's just early, then return precautions that are very strict. Repeat beta HCG in about, I have 24 to 48, but really it's about like 48 to 72 if you're not worried about them. And these are usually the patients that I do warm handoffs to. I call somebody and I say, this patient's coming back to you. Or I give them an email if it's in the middle of the night through the electronic health record. This patient's going to come back. You need to watch out for them because they need their follow-up. And then if you're concerned about ectopic, if they've got something else that's going on, then radiology imaging, if they seem like they're stable and you're just like, I don't know if there's really like a problem here. Maybe it's just early. I can't really tell. This is why we have consultation with radiology on these patients, is that you can go have them take a look and see if they can find anything. If they're unstable, then it's just an immediate OB consult. If there's time to get radiology, you can always ask the OB if they want you to do it. So just one more chance to reclassify this in your mind for management. If you see nothing in the uterus at all, it's either early pregnancy, it's an ectopic, or they've already aborted completely. And that's usually their symptoms should be getting better if they've completed their body has completed getting rid of all those products of conception. If there's something in there, it's a threatened, an incomplete, or a missed abortion. And those are kind of the three things that we're looking at. All right, obviously the complete abortion is the caution. You have to be cautious about diagnosing that one, right? Because a complete abortion looks exactly the same as an ectopic pregnancy. The cervix is closed on exam. There's nothing in the uterus. All right. Remember this little trick down here. I misdiagnosed somebody when I was a second-year resident. I found their cute little pregnancy. I was like, oh, you have it. I showed them the heart rate. I showed them everything. 3 days later, I found out that patient actually did have an ectopic pregnancy. She did fine. That ectopic pregnancy kind of resolved on its own and was gone on her repeat ultrasound that she had a couple of days later. But it has certainly taught me that when you find that little pregnancy in there, you got to look at the big picture one more time to make sure that there is a uterus around that pregnancy. All right. So quick reminder, this is the disposition slide. Now we're going to go through those 4 patients. So we have a 21-year-old, 22-year-old, 23, and a 24-year-old. I gave them all the same beta HCG to take that out of the picture. It doesn't matter anyways. Which patients need ultrasound? Obviously all of them. This is the 21-year-old. She has a closed cervical os. The way I do this is I have the patient come into the department, like they meet them. I do their transabdominal ultrasound. I say, okay, I need you to pee, give us a urine sample, and then get ready for the pelvic exam. Leave the machine in the room. Go get the endovaginal probe. By the time I'm back in the room, they have an empty bladder, and I do their pelvic exam and then follow up with an ultrasound. All right, so this is the ultrasound that we get. That's why by this point in time, I usually know whether or not their cervical os is closed or not. So she has a closed cervical os and she's got this. What is it? Excellent. Gestational sac. I've got like 4 people who ended up in this room with me, so they're stuck with having to answer things. Yes, gestational sac. We're not really sure what it is. Close follow-up and serial HCGs because she otherwise looks okay. Her left lower quadrant pain's not too bad. All right, lower abdominal cramping, bleeding, beta HCG 990. She also has a closed cervical os. What does she have? She says, I'm really anxious, and she's tachycardic. She's got free fluid in there, so you do her right upper quadrant view. Whoa, I'm not sure why it's way up there on the screen, but luckily we can see the part we need. Yeah, so what do we do now? Man, if I did a laparoscopy, I can guarantee that her fertility success in the future is going to be very, very limited. We'll call it B. 23-year-old focal left lower quadrant pain. She's having bleeding with clots. Her beta HCG is 990. She has an open cervical os, and this is her gestational sac down here. So she's got this kind of irregular gestational sac, just full of fluid. She's got a little bit of fluid up here, but it's not too much. And then this, what you guys are seeing down here, this is just vascularity within the uterus. That's fine. That's what uteruses sometimes look like when they're pregnant, when you have this like high resolution probe. So she is probably what? Yeah, she's probably a miscarriage. So she's open cervical os, so she is a incomplete miscarriage. And then last one, lower abdominal pain, no bleeding. She has a closed cervical os. This is what we see on our ultrasound. What have we got here? It's a baby.
Miracle of life.
Miracle of life. Absolutely. When you guys do this ultrasound, just like pay attention to like the cortisol level, just like drop a little bit when you find these pregnancies. It's amazing. You're like, thank God you're okay, and I can just send you out the door. I'm not sure if it's because they're okay or if you can like stop diagnosing them and working them up. One of the two. All right. So this is our 4 women that the beta HCG helped us so much on. So just remember that. So you don't need it. You just want to make sure that you're being cautious and sending these people home with good follow-up instructions if they're not keeping them in the ER. Even this person here, we need to worry a little bit about her in the future, but currently she is safe from having an ectopic pregnancy. So remember, your required ultrasound views. You want to do the ultrasound of the uterus. I would prefer you do it transabdominal first, but you want to do a scan for the uterus in 2 planes, and then you can zoom in on the endometrial cavity and do that in 2 planes, and then repeat this, the whole thing, both the uterus and also the gestational sac views with the endovaginal probe after they're emptied their bladder. If you find anything on either of those, make sure you measure the gestational age, and if you can find a fetal heart rate, go ahead and measure it. If it's above 100, that's a good sign for their pregnancy. Although in early pregnancy, it's sometimes just a little bit slow because they haven't quite caught up with the world yet. And that is all I have.